Hi, my name is Beth McLeod, and I'm going to be doing my evidence-based practice presentation on shoulder dystocia. I am doing my UK synthesis at UK's Birthing Center. UK's Birthing Center is located in central Kentucky. It specializes in high-risk pregnancies and deliveries. Additionally, there is a 26-bed normal nursery and a Level 3 neonatal intensive care unit. There are 12 beds and a triage with 4 rooms. The day shift has approximately 5 to 7 nurses and 1 scrub technician who helps with the cesarean sections in the OR. There are multiple residents and attendings on site, as well as an anesthesia team, and 2 ORs that help with the C-sections and 1 that's used for cerclage and D&Cs. A childbirth preparation program is offered. It meets once a week for 3 weeks and is recommended once the mother is at 28 weeks. This program helps the parents learn about the stages of labor, the timing of contractions, and how to know when to arrive at the hospital. Additional programs include baby basics, such as bathing your baby, diapering, what a normal appearance is, cord and circumcision care, etc. Additional classes include infant CPR, nursing your infant, Happiest Baby on the Block, which includes postpartum depression discussion, Big Brothers and Sisters Are Special, and multiple birthing center tours. So what is shoulder dystocia? The American College of Obstetricians and Gynecologists defines shoulder dystocia as a birthing process that requires additional obstetric maneuvers following failure of general downward traction of the fetal head to effect delivery of the shoulders. In other words, it occurs when the fetal shoulders cannot be delivered under the symphysis pubis or out of the posterior pelvis. It's further defined as a prolonged head-to-body delivery time, more than 67 seconds. It's also further classified as a mild or severe case. A mild shoulder dystocia requires only McRoberts maneuver and or suprapubic pressure to effect birth of the shoulders, whereas severe shoulder dystocia requires the use of wood screw maneuver or extraction of the posterior arm. Further down in the slides, I will discuss those maneuvers in more depth. So how common is it? Shoulder dystocia is a rare birth emergency that occurs in approximately 0.2 to 3% of all births. Its causes are obesity, prenatal weight gain, and gestational diabetes, which tends to lead to weight exceeding 4,000 grams for the infant. When weight exceeds 4,000 grams, the fetal body assumes more adult proportions, with the width of the fetal shoulders exceeding the biparietal diameter of the head. The fetal head is born, but the anterior shoulder becomes trapped behind the symphysis pubis, or the posterior shoulder catches on the sacral promontory. When looking for advice from the Institute of Medicine, women of normal weight are advised to gain 25 to 35 pounds for a healthy pregnancy, but obese women are asked to only gain 15 pounds. Obesity is a risk factor for many perinatal problems, including gestational diabetes, preeclampsia, stillbirth, macrosomia, prolonged labor, or shoulder dystocia. Excess weight gain provides calories for excessive fetal growth. Women with large weight gain should be seen more often during pregnancy, every 2 weeks instead of monthly, to provide more frequent nutrition coaching. Gestational diabetes, complicated by obesity, poor glycemic control, or excessive weight gain, increases risk for shoulder dystocia. Advice is that women be screened at the first trimester, first prenatal visit, with repeated screening later in their pregnancy. It's also important that the estimated weight of the fetus be assessed for macrosomia, because if the fetal chest circumference equals or exceeds fetal head circumferences, which can be measured by palpation or ultrasound, this can indicate shoulder dystocia risk. Additionally, women who have had shoulder dystocia in the past are at an increased risk for subsequent shoulder dystocia, with a 9.8 to 16.7% risk. However, it often affects women with no risks at all. Can it be prevented? In antepartum, what they're saying is not really, because it's unpredictable as to whether or not you will have shoulder dystocia. However, antenatal education on weight management, diabetes, and macrosomnia can help decrease the risk. In intrapartum, the actual labor part of pregnancy, risk assessment should include fetal weight, fetal height, assessment of pelvic adequacy, and fetal position. It's important to know all of these prior to going into labor so that family and environmental preparation for shoulder dystocia management can be applied, such as informing the mother what may happen, getting her to practice the McRoberts maneuver, setting up the OR, and informing a team, such as NICU, that there might be a baby coming with possible injuries from dystocia. Some important signs to look for during the labor process to indicate shoulder dystocia may or may not be may be happening is turtling. Turtling occurs when the head emerges and then pulls back tight against the perineum. It's just like it sounds. Turtling is if you were to imagine a head from a turtle popping out of its shell, but that shell being a little too tight, and when it tries to slide its head back in, it gets caught on the ridges of the shell. An additional sign to look for is the other sign involves failure of spontaneous external rotation and restitution. So what happens during a shoulder dystocia emergency? Midwife or physicians usually perform the maneuvers for impacted shoulders, but nurses must still understand safety measures and the actual maneuvers that are used, such as McRoberts and suprapubic pressure, and need to participate in drills. Since this is a rare occurrence, everyone should participate in drills to be up to date as to what to do and not cause such a chaotic scene. Nurses are asked to summon for additional help, such as more nurses, more doctors, or the NICU team. Nurses are also expected to help the mother into the McRoberts position. The McRoberts position is done by flexing the maternal thighs towards the maternal chest. McRoberts maneuver slides the pubic bone over the anterior shoulder. If the McRoberts maneuver does not dislodge the dystocia, there might be suprapubic pressure applied. Optimal suprapubic pressure is accomplished by placing a clenched fist or the heel of the hand behind the anterior shoulder and pushing the shoulder toward the fetal chest and down. This pushes the shoulder into the larger oblique diameter of the pelvis and presses it under the suprapubic bone. Adequate force must accompany a suprapubic pressure. For the most effective strength, the nurse or whoever is applying the pressure may place the second hand on top of the clenched fist with both elbows straightened and lean into the maternal abdomen. Additional maneuvers, if that does not work, those two maneuvers, which is almost guaranteed usually to do the trick, additional maneuvers can include Rubens maneuver and wood screws maneuver. I'll go into that a little further down. A last resort may include breaking the infant's collar or cesarean section. Additionally, a nurse needs to keep accurate documentation and timekeeping because there have been some cases where there have been liability issues with the injuries that have occurred. So it's important to keep accurate documentation, timekeeping to keep the nurses and the doctors safe, as well as documentation on the baby itself when it's born, such as APGAR scores, bruising, injuries to the arm, etc. This is just a picture explaining or showing what McRoberts maneuver is and the suprapubic pressure. So that's the nurse, and she would be the one holding the heel of the foot and pressing the thigh against the maternal chest. So what does this mean for baby? The newborn may be just fine. However, newborn injury may include bruising, minor bruising, can include a fractured clavicle or humerus. These are temporary injuries and heal with splinting of the arm. Recovery is spontaneous and may take 3 to 6 months to heal. The more pressing issue that causes claims in court is the permanent brachial plexus injury, and this is a brachial plexus injury is an injury to the brachial plexus, the network of nerves that send signals from your spine to your shoulder, arm, and hand. A brachial plexus injury occurs when these nerves are stretched or, in the most serious cases, torn. This happens as a result of your shoulder being pressed down forcefully while your head is pushed up and away from the shoulder. Most newborns recover spontaneously from brachial plexus injury with physical therapy. Only 5% to 22% of infants have a permanent injury. In more severe cases, when the baby may be stuck in the pelvis too long, you can have hypoxic brain damage or even death. What does this mean for mom? The number one thing to assess for afterwards is the risk for postpartum hemorrhage afterwards. Fundus massage can help to stop the bleeding, as well as breastfeeding, which works the same way as in giving Pitocin, which is to increase contractions of the uterus to help stop bleeding. Additionally, you may have bruising and lacerations, which are common around the vagina area, and ice packs can be used for edema and pain. Effective and therapeutic communication is also very important and necessary because many women give birth to these children, and when this dystocia incident happens, they blame themselves. They need to be aware that it was not their fault, and they also need to be made aware of what to do now that their baby may have some of these injuries. It's important to also include the father in these discussions. And last but not least, because this is a rare emergency, it's important to stay up to date and know what to do. So this helper can help you remember what to do in this case. H is to call for help. Call for extra people like nurses and doctors and the NICU team. E, I didn't go into much detail about this earlier because the research that I read is kind of conflicted, but the doctor can evaluate for episiotomy. Shoulder dystocia results from shoulder bones impacted against the pubic bone, not against soft tissue. So therefore, an episiotomy may or may not improve outcomes, and it's not really a necessary component of shoulder dystocia management, is what some research is saying. L is legs, from McRoberts to hyperflex and abduct of the hips, so pushing those thighs towards the maternal chest. P is for suprapubic pressure. You want to do a combo of McRoberts and suprapubic pressure, and these two things should normally alleviate the problem. However, you may have to get into E, internal maneuvers. This is when Woods or Rubin can come into effect, and Woods is to insert a hand into the posterior vagina and rotate posterior shoulder clockwise or counterclockwise. R is to push posterior anterior shoulder toward fetal chest and adduct the shoulders. And last is to remove the posterior arm, the delivery of the posterior arm. Are there any questions?